So, can we move to the next case? This is from SSKM and IPGME&R. Dr. Subhajit Malakar, kindly present your case.
Good evening, respected teachers, my colleagues and my juniors. I am Dr. Subhajit Malakar from IPGME&R SSKM Hospital. Today I am going to present a typical case of a right renal RCC with IVC thrombus extending up to the atrium with a single mediastinal lymphadenopathy. The patient is from West Bengal, a 45-year male presented with a history of right flank pain for the last 4 months. And the pain is intermittent in nature and it's in right flank, which was dull in nature, gradually in onset, localized, moderate in intensity. There is no history of any significant weight loss, no history of any hemiaturia, no history of any lower limb swelling or scrotal swelling, no history of cough or any seizure or loss of consciousness. The patient is known hypertensive and on medication for last 2 years, along with the patient is smoker. Other histories are generally normal. On general examination, the ECOG status is 0, no pallor, no lymphadenopathy. Other general examination does not reveal any lower abdominal, lower limb swelling or no scrotal edema. On systemic examination, the main important findings is a right flank full, which and no other inspectory findings. On palpation, a lump of about 10 to 8 cm in right hypochondrium region extending about 1.5 cm. Above the right iliac crest, surface smooth, margin irregular and not crossing the midline, forming consistency. There is no varicocele and other corneal auricles and other peer examinations normal. Systemic examinations is within normal limit. Thus, other systems are also within normal limit. On investigation, we have seen a hemoglobin is 12.7, total count is 8,700, platelet is 3.4 lakh. Serum calcium is 9.9 milligram per deciliter and LDH is 1.5. This is the urine report which does not reveal any proteinuria, but there is pus 1 to 2 and no growth, no RBC. Other investigations are normal. And then we have done a USG which says a heterogeneous SOL measuring out 7.3 into 5.9 centimeter with peripheral increasing vascular flow noted in the mid-pole of the right kidney. There is no lymphadenopathy, other kidney is normal and other findings are also within normal limit. This is a CT scan which also reveals about 8 centimeter mass arising from the right mid and lower polar region of the right kidney with a heterogeneous mass of right renal mid-polar mass extending with central necrosis measuring about 83 into 72 into 58 millimeter and mass invades the right renal vein, infradiaphragmatic IVC, which is markedly distended, measuring about 3.8 cm tumor thrombus within. A bland thrombus is seen in the proximal left renal vein, fat vein is maintained, and no lymphadenopathy. This is the CECT report. After that, we have done a renal Doppler, which reveals the ecogenic material noted in the IVC extending from the umbilical region up to the right atrium and right renal vein, completely obscuring the lumen. Ecogenic content is taking up the vascularity and features are suggestive of tumor thrombus. Further that, we have done a CECT thorax. CECT thorax is saying that there is 29 into 24 millimeter. Sorry, it is a heterogeneous enhancing lesion in the mediastinal, likely metastatic. After that, we have following that we have done a transbronchial biopsy and a through-cut biopsy of the kidney. With the kidney biopsy reveals a clear cell carcinoma and the transbronchial biopsy reveals a metastatic carcinoma. So our diagnosis is it's an atypical case of a right renal RCC with IVC thrombus extending up to the atrium with a single solitary mediastinal lymphadenopathy. Then we proceed for after that we proceed for pazlovirin therapy and the patient is now on 800 mg pazlovirin therapy.
Was you certificate?
Sir, because if the patient have a IVC thrombus and he is not having any symptoms that is related to IVC thrombus, such as the patient not having any limb swelling or no scrotal swelling, no varicocele. In fact, the patient on the urine report also we can't find proteinuria, which is very much common in a patient with IVC thrombus. Number one. Number two, the patient is totally asymptomatic. There is no stigma of any symptoms related to the IVC thrombus. So we are telling it's atypical. And another thing is, if the patient is having such a big mediastinal lymphadenopathy, the patient should have a retrovenous lymphadenopathy also. But the reports, both USG and the CT scan, does not reveal any points towards the lymphadenopathy in the retrovenous region. So I am considering this case to
No,
be
what
an
is the explanation of total blockage of the vena cava
yes.
in spite of without having any lymph node?
So the patient may develop collaterals,
Yes.
so that may be the cause which is the patient is not
Very
having.
common that he has developed collaterals.
Do you expect any abnormality in the venous drainage or in the abdomen?
No, sir.
Would you look for that one?
Yes, sir.
Why would you look?
Sir, because if there is any IVC thrombus totally occluding the venous outflow, that is, if the blood cannot able to go towards the heart, there should be venous engorgement in the anterior abdominal wall, and when we try to milk it out, we will like to see the direction of the blood flow. The blood flow will be from the lower part to the upper, means from cranial, caudal to cranial. If there is any
It's a suprahepatic involvement, isn't it?
suprahepatic.
It's gone to the venous.
Atrium, sir. Atrium, sir.
So there has to be portal obstruction as well.
Yes, sir. That should be.
So that's how you look at it. This is atypical, I agree with you.
Yes.
But nothing happened here.
No,
But
sir.
these are the collaterals which opened up here.
But in
The
this
second thing I would like to ask you, for the exam, what is the stage? How would you describe it as a stage? Taking into account the venous thrombus and the
it is T3C N0 M1, because I can't say about the lymph node status in the retroperitoneum. No. And as there is a distant metastasis, so I am saying it's M1.
TCY.
NGO, why is it? Ideologically, it has been not very difficult. Suppose you are going for open heart surgery. What are the sites of cannulation? Just say cannulation. Where will you put the cannulae in open heart procedure of the IVC thrombus? This is a good procedure. Cannula for veins, cannula for arteries, putting in the type of machine. What are the sites of cannula?
Not a very simple question though, but still.
It's written in Campbell.
Picture is there in Campbell.
Clear.
In Campbell, good picture is there. I am not telling outside the book.
Detailed diagrams.
Diagram, good picture is there.
Sir, in brain,
This was asked by sir in gold medal exam as well. To all the
One is the vein,
yes, sir.
either atrium or parallel.
SBC and
Another is
femoral, means before opening. After that,
and the artery.
aortic means
Two side veins from two sides. Artery from
I don't know the arc of aorta. Arch of aorta and lower is right femoral, sir, femoral.
vein two sides, from two sides you have to drain it. You are bound to drain. And put this to the artery not two sides.
I've got a quick query. How long you are planning to put the patient on trazopam, and when you are planning to operate?
Sir, according if we stratify the patient according to IMDC letters, it has 6 points. So when we try to stratify the patient, we get that I would like to show you the investigation. The patient is having hemoglobin is 12.7, TLC is 8,700. According to IMDC criteria, the TLC must be in between 4,000 to 7,000. And other factors are within the limit, IMDC criteria. So this patient is having only one risk factor, so it falls into the intermediate group, risk group. And according to Carmona trial, we know that if the patient having an intermediate risk group, then we should go for, we don't go for a surgery, we generally go for a either TKI or immunotherapy that are available nowadays. So if the patient is having an intermediate risk group, then it's better to give a TKI or IO, because the lifespan of these patients are generally lies about 22.3 months.
But MSK or MD Anderson, there's an LDH.
Yes, sir. In that case also they have a LDH. If
We
we
have got LDH.
if we take the MSK criteria, then the patient is having LDH 115, which is much more above the normal. The normal is about 105 to 333 international unit per liter. So in that group also it is under the intermediate group, whose lifespan is around 10 months.
So in high risk group, what will you choose?
Sir, I will go for TKI or IO because there is no indication of any nephrectomy, regular cytotherapy or if the patient is having a symptom, then we can go for a palliative nephrectomy. But there is no role of any nephrectomy or over the TKI.
What TKI and what IO?
Yes, sir.
What TKI? Oh, you said TKI and IO.
Yes, sir. According to the recent guidelines, EF guidelines, if there is intermediate or poor risk group, that the patient may be started with nivolumab or ipilimumab, or so we can start pembrolizumab or atezolizumab or pembrolizumab or lenvatinib or ipilimumab with lenvatinib. This is the first line. If there is failure, then we can start either sorafenib or nivolumab. Pembrolizumab is the second line. If the patient this is for the poor or intermediate risk, if the patient is having a clear cell carcinoma and the patient is totally chemo-naive. In later we can also use some second line drugs such as nivolumab, carboplatin.
Yeah, but what you are just saying, the current thing is still very hazy.
Yes,
But the thing is that you have to, cost factor is important thing. So IO is very expensive, the TKI is less expensive. So MRCC, the TKI is the one you can do it as a neoadjuvant. And then if there is improvement, you go for the upfront surgery there. And then you give the IO, the pembrolizumab and the context 1.
The idea of presenting these case was for the residents. If you find a patient with IVC thrombus, what are the things you should look for? If you find a patient with IVC thrombus, again go back to the patient and look for the features of IVC obstruction. If you find that for one patient, if you do not find any features of obstruction, you'll be sure that patient is having good collaterals. If you have to operate, this is going to be easy operation relatively compared to patient who has features of IVC obstruction. That is first thing, clinical importance. Second is you need to differentiate between the bland thrombus and the tumor thrombus. How do you know? You look for the arterial phase of the tumor. If you find that arterialized thrombus, there is a tumor thrombus, you find which is not enhancing within the arterial phase, you find it's a tumor thrombus. Third thing is you have to know whether this is a thrombus which is inside the lumen or this is a thrombus which is invading the IVC, because the stage changes, the management changes. Okay. Fourth thing is you need to know what are the other investigations you should do in a patient who has IVC thrombus. Is it Doppler, is it MRI, or CT is sufficient? What is the stage? Whether there is any liver collaterals, because if you find any liver collaterals, it is more difficult to manage in these patients. And if the patient has a supradiaphragmatic extension, you need to have the help of a CTVS surgeon. So the idea of this, presenting this is this. And any patient with IVC thrombus does not mean you need a surgery. You need to stratify the patient with the iron desaturation and then decide for the surgery. Obvious symptoms, yes, you have to do a palliative nephrectomy. This patient does not have any systematic symptoms or hematuria, so this patient was managed on, according to IVC intermediate risk, is put on TKI because we do not have an access to IOs. Okay, that was the message we have to do. And one thing you missed probably is this patient has a thrombus on the opposite kidney also. So in exam you will be asked, if you are given a choice of doing a left-sided radical nephrectomy versus a right-sided radical nephrectomy, because both the patients are, yes, which one you will prefer? So that you need to know. Okay, which one? Anybody? Who is for left side, who is for right side? Think of the anatomy, it's very easy. You will go for right side. Okay. Who is for left side? What is the difficulty? What happens? What are the steps of cannulation of? What are the things you should make a sling?
Clamping of the thing of the
Sir, in left side radical nephrectomy, we need to clamp the we don't need to clamp the right side artery. As it is
Left side nephrectomy, you don't need to clamp the artery.
right side for the bland thrombus.
Do you need to take control of the right renal vein? In case of left radical nephrectomy with IVC thrombectomy, so what will happen if we clamp the right renal vein?
The congestion will happen. The renal
Okay,
congestion.
left side?
There is, left side there is
Presence of collateral.
presence of gonadal vein and
Yes.
adrenal vein. So even if it is completely clamped,
So what extra step you need to do on right side? Left side nephrectomy, what extra step you need to do on the right side?
So we have to clamp the artery also.
the artery,
Clamp the artery.
both-
That is the difference in asking exams. In left side, mostly you do not have to clamp the left renal artery because you have collaterals to the left renal vein. Otherwise, left side is difficult. So the extra step you need to do in the right side.
Which one will you, once you saw the thrombus, if you have got all the facilities, would you go for the MRI or the CT? You have done everything now. Now you have seen the thrombus, which you are not sure whether it's how much is the blood, how much is the thrombus, and whether it's other renal vein as well. So which scores better? Is there a role of PET scan, or you are happy with the MRI? What is your take?
So MRI only helps to understand that whether there is infiltration of the wall or not. So if we get a MRI, then it may change the stage of the tumor if there is a bulb involvement. And by and also by seeing the contrast, we can detect that whether it's a brain thrombus or a tumor thrombus. That we can do using both CT and MRI.
So contrast is the
Contrast
answer.
is used.
But the MRI gives you a better vision of the thrombus.
For venous system, MRI is better than,
MRI is
at least
better.
in exam you have to take. But almost now CT is improving also.
Yes, of course, with the
But,
contrast.
The thing is, if you find a blind thrombus, mostly these blind thrombus are more proximal towards the limbs, lower limbs. So you can keep a blind thrombus intact inside the venous system, putting a IVC filter. But if it is a tumor thrombus and if you are going for a radical intent, you cannot put this tumor thrombus inside the system. You have to remove this one. Blank thrombus, if you are sure from the CT scan or MRI it's a blank thrombus, you can keep it there. You don't need to go extensively downwards. You have to put a IVC filter. That is therapeutic difference, surgical difference.